Billions are being invested in digital health, yet so many tools sit unused because clinicians don't trust them. Why is it so hard to build technology that doctors actually want to use? That's exactly the question my guest today, Dr. Kalie Dove-Maguire, has been tackling as both an emergency physician and product leader. Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episode. I am your host, Dr. Ruth Adibuya. Dr. Kalie Dove-Maguire is an emergency physician and chief product officer for Evidently, a health technology company building tools to embed evidence-based decision-making into clinical workflows. She trained in emergency medicine at UCSF and has combined her frontline experiences with expertise in digital health product development. Her work focuses on creating clinician-trusted technology that reduces friction, improves care delivery, and addresses inequities in healthcare. Dr. Dove-Maguire is a nationally recognized speaker on health technology innovation, clinical decision support, and the future of evidence-based care. Thank you so much for being on the show today.
It's a pleasure to be here.
As an emergency physician, you have made life or death decisions in minutes, often with incomplete information. How did those moments shape the way you think about building technology that clinicians can actually trust and use?
I like to refer to the emergency department frequently as a data-free zone. No matter what studies you have, oftentimes you either have incomplete patient information or a patient that wouldn't qualify for any clinical study. So you're in a data-free zone, both from a background and nobody has really tried XYZ medication on somebody with florid heart failure and also cardiogenic shock. Also, they have a leg that just got amputated because they were in a traumatic injury. That patient population for a clinical study does not exist. Then you're left with, okay, what information do I have at hand? And how do I validate it? And how do I go about making a decision based on that incomplete information? That now is just based on my experience and where resources are. That's the baseline understanding. And anything you can add on top of that is icing on the cake. So for any sort of thing that I develop, I try to make sure that it's extremely transparent and verifiable. We have this trust but verify mantra where we show people, but we also allow them to verify it. And over time, that leads to trust. So as you learn how to trust your own instincts with that patient population you've never seen before, you can also learn how to trust a digital tool as you work with and understand it. But if you don't have trust founded in principles of transparency and verification, nobody's going to trust it. So that's where I take that trust and transparency and apply it to our digital world.
That makes a lot of sense. Research shows clinicians need decision support they can rely on in high pressure moments, not something that adds more uncertainty. That leads a little bit into your own journey, where you made the leap from emergency medicine to health tech leadership. What experiences showed you that the status quo wasn't working and how that inspired you to be part of Evidently?
I have experiences that stick out in terms of things like this could be better. I was working in an emergency department in Central California, really high acuity. If you've watched The Pit, it was basically like The Pit every day, minus the mass casualty. We had codes coming in every 10, 15 minutes sometimes, and you would only have a couple of providers. At that place, they had an EMR that was not standard. The only way you would know that somebody had a PET CT ordered, let alone had bleeding in their brain, was happening to walk by that fax machine and noticing there was a paper there, picking it up and reading it, and then trying to remember whose patient that was. If you'd never seen the name, you had to find them on the trackboard and figure out, oh, they're in the waiting room. They haven't even been seen yet, but they appropriately had a triage CT ordered. That was just one of those moments where I was like, there has got to be a better way to facilitate care delivery and digital engagement because I'm interacting with a screen. Why is that so siloed information? Throughout my career journey, I had built tools that helped in incremental ways solve some of those linkage problems with information in silos and trying to see if we could move those decisions upstream. And it wasn't until after residency when I had decided that I wanted to learn more about entrepreneurship and then eventually decided to teach myself how to program, where I was like, we could probably fix some of these things if we just married some siloed information. MacGyver, for lack of a better term, like in the ER, there's nobody else to call. Sometimes you have to figure it out, even if it means duct taping a popsicle stick to somebody's finger to make a splint. And that sort of emergency medicine, figure things out, get it done, and rely on yourself is what I took to that career of digital medicine. I was like, okay, I'm just going to figure this out. I'm going to decide to take these tools and apply them in a different way, see what I can do. Yeah, it's been an interesting career journey, but the skills I learned in the emergency department I use every day for problem solving.
I love the vivid example you gave around results arriving by fax machine and just happening on it. And literally a patient's life could depend on someone noticing it.
Yeah. You're like, how? This can't be where we're at. And at the same time, there was people walking around with Google Glasses. And I'm like, okay, so you have Google Glasses and I am relying on a fax machine. Didn't make sense in my head.
Yeah, I think it also highlights how far we still have to go. Even now, studies show that clinicians spend more than a third of their workday in the EHR. How do you design technology that reduces that burden while preserving clinical judgment?
This is exactly the problem that Evidently aims to solve. So most medical records are around, we used to say the last studies were like 300 to 400 pages, which is like asking somebody to read The Hobbit. It's been increasing. And now recent data says it's around 1,200 pages, like the whole Lord of the Rings trilogy is what you're asked to consume in about 5 minutes. And then you get a pop quiz. If you get it wrong, you might hurt somebody or get sued. The stakes are high. We are set up to fail every day. This technology allows us to basically read that whole chart for you, index the entire thing, and then pluck out the things that are going to be most relevant to me as an emergency physician. I'm talking to Jane Doe. She's 66. She's got biventricular failure, a history of kidney disease, and just had a big GI bleed. That's the information I need from that entire book to then frame up my context to start my decision-making. If I was a cardiologist, the 3 bullet points from that entire Lord of the Rings trilogy is going to be different. That's where technology comes in. It can read it, it can prep you, and it can give you that information to set the context. But it's not going to tell you how to treat the patient. It's not going to tell you how to diagnose it, but it can tell you all of the evidence in the patient's chart, even flag the things you may have missed. They had an echo and their EF was 30. But your note said it preserved ejection fraction. Do you want to double check that? That's where we have the opportunity for the technology to fill in that understanding of the clinical context and then still preserve the physician's ability to make a determination.
That ability to surface the most relevant information while giving clinicians options to go deeper feels like the balance point in creating tools. But another point around this is that even when tools aim to do this, we also know that alert fatigue is an issue, and studies are showing that more than half of alerts get overridden. What are some of the design principles that help you avoid that fatigue and instead build the tool that clinicians will use?
Evidently is embedded inside the EHR. It reads everything that it has access to. So if you're an Epic, that means care everywhere, scanned media documents, all of that. It organizes it and presents it to you. When it presents it to you, it allows you to verify everything is true because within one click, you can get down to that original source information. So that's the framework. And when I first saw technology like this, like LLMs and everything, the one concern I got was like, great, I'm going to have to now take something that might hallucinate, presenting information out of context without my ability to verify it. It's like taking a presentation from a new resident you haven't met before. You have no idea if you can trust them or not. They seem confident, but are they like accurately confident or are they overconfident? You can't judge it without context in the framing. And that's what Evidently does differently is we're not just an LLM giving a narrative summary without any context around it. We present things the same way a clinician wants them. This comes from developing the solution with clinicians alongside developers from day one, saying that you can't give me anything in isolation. You're going to tell me they have heart failure. I'm going to ask you about the kidney disease. I'm going to ask you about their medications. I'm going to ask you about the echo. And so everything that we present is in context with the things that are related. And we can do that because we have a bunch of different technology that we add together. So we have a knowledge graph that knows what different things are related to heart failure. We have an LLM that can link the conversation parts together or the narrative. But we also have NLP that'll map the entire record for you. So we don't believe in isolation. And that comes from the way clinicians perceive things. We need it in context of the whole medical history. And that's been the development ethos from day one.
As you were talking and explaining how the tool worked, it surfaced to me how from the outside looking in, if someone is investigating this tool or just hearing about it at a surface level, there could be misconceptions like how does it usually work? Your clarification of how this specific tool works is helpful, but also makes me think about misconceptions clinicians have about AI tools. So can you talk about what you have heard are the biggest misconceptions and how you have addressed them either with this tool that you have now or with others?
Two come to mind. One is a hallucination and the other one is the bias. Those are very valid concerns for anything that has an LLM underpinning. And so an LLM is like your ChatGPTs, your Claudes, whatever you're asking to help write your emails. They are amazing at narrative-based sentence construction, but the early ones hallucinated all the time. You could not trust that thing to save your life, but it was really good at writing poetry because it could be very creative. However, when you're taking care of a patient, you want facts, you want them verifiable. As the underlying LLM technology has matured quite a bit, so that hallucination rate has also decreased, but you can also augment it. And that's where I think a lot of people had their first experience with ChatGPT was like this thing that was a little bit wild and hallucinated all the time. So they think, oh God, don't put my patient data near that thing. That's the framework we start from when they see it in practice. We've done so much work to pre-process that data as well as do post-processing that when you see it, it's so verifiable. We take all the mystery out of it. It's the least mysterious application of AI you'll see because we show you where it came from. There's no black box and everything is traceable. That's one misconception is the hallucinations. We can really mitigate that. The second one is the bias. There is a decent amount of bias in medical care in general. Like, I don't think that's up for debate. Then you think about applying technology to that. And I think about it in two ways. One is you're going to have the hospitals that apply the technology and those that don't. And that's going to create a huge discrepancy. And the second one is when you apply technology that does chart summarization, what are you summarizing? A lot of times people expect this to mitigate the bias. It's going to reflect the bias that already exists. Some people are like, oh, you might have mistakes, but we've done a lot of this work and the mistakes are in the medical record. So when we actually look, they're like, hey, this patient doesn't have cancer. And we're like, you're right, they probably don't. But you have hard evidence of the chart that somebody said they did. One example, we deployed this at one of our hospitals and they found this patient that was like, there's no way this patient has prostate cancer. You click in it and you see there was original diagnosis 6 years ago at a prostate cancer clinic visit. There's no surrounding evidence. It makes it obvious that the lack of evidence is a strong indicator. But what happened is somebody opened an encounter and they couldn't figure out how to close the encounter. So they had to save it and they weren't allowed to save it without a diagnosis. They popped in whatever diagnosis they had. And I think those are the kind of things where there's a lot of medical errors in those charts, but you don't oftentimes recognize them. And once you get a tool that makes it obvious, here's data that is discrepant from the rest. And how do you reconcile that? The bias will still exist, but you have a tool to see what is appropriate and layer on decision support that says this is an appropriate diagnosis or this patient might qualify for a different treatment pathway. Whereas before, we're shooting from the hip and hoping for the best. I don't think that traditionally works out super well.
Yeah. I want to make sure we're defining terms, but just in case folks are not aware, can you define what hallucinations meant in this context?
Great clarification point. So hallucination is a complete fabrication of a concept. So if we had an LLM that said, this patient has heart failure. Now, the hallucination there would be, if you clicked on it and found no supporting evidence, you're like, okay, this might be a complete fabrication. I see no heart failure anywhere, which is different than accuracy and being incorrect. So we say this patient has a history of prostate cancer. When you look for supporting evidence, you can see there's evidence, but it's not supported by anything. So that's different. That's not a hallucination, but it's a reflection of the inaccuracy in the chart. We're applying this technology to our charts. We're making it a lot more obvious to see where the discrepancies in the chart and the data that doesn't reflect the actual diagnoses just become a lot more obvious when you can see there's zero supporting evidence for it. But that's not a hallucination. Whereas if I had completely fabricated the idea of prostate cancer, that would be a hallucination. But those rates are very low now.
Thank you for defining that for us. Going back to what you were saying about how there has been a lot of work done to make sure that hallucination rates are going down and understand why that could be a misconception or concern from clinicians. It seems like we've gone far, and I'm sure there's a lot more work being done to reduce those rates. And also, I think your point about bias, also very well taken. If medicine already carries those structural and documentation bias, then it's just going to mirror that into reality. Raises another challenge because even if the information is accurate, it needs to fit into the clinician's world. And from what you're talking about with evidently being integrated into EHR, it seems like that's like the perfect kind of connection. From your experience, what have been the biggest barriers to integrating AI tools seamlessly into some of the existing workflows that clinicians might be practicing in?
Taking a step back from my evidently role, the biggest thing is trying to create something that doesn't exist into their current workflow. It has to be integrated into the existing workflows to have any buy-in. So my prior company, I worked at a company called Carbon Health and was fortunate enough to work on the team that was one of the first groups shipping an ambient scribe to our population at scale. But that was at ground zero. So nobody had exposure to this and trying to figure out how to use it. So we did a lot of work there to try to figure out, okay, you're already in the platform. It's already integrated. But how do we get adoption to trying a different method of doing something? And that turns out to be all social. It is all social. It is, hey, what does your friend use? What is that person you respect that is a clinical savant or somebody that goes home early every day? And you're like, what are they doing that I'm not? So it's really that social distribution that tends to be the biggest indicator of adoption because step one, integrate it into their workflow. If it's X outside of their workflow, they're never going to do it. And then step 2, have a champion that understands the tips, tricks, limitations, and benefits. And that's how you get adoption to spread.
That's excellent context. I love how you started with, if you create something that's outside of the workflow is a non-starter. The fears that might come around the use of these tools is like it's yet another thing and yet another tool to use. Clinicians look to peers or respected champions to embrace a tool obviously echoes what we've seen in a lot of innovation research across medicine. So I suppose that's really consistent. That makes me wonder about frontline voices. How do you involve physicians, nurses, and other clinicians in the design process to make sure that the tools fit naturally into their roles?
This is one of our core principles. I come from a perspective of assume nothing. Even though I am an ER doc, I've worked in a lot of different environments. I just cannot assume that we are all going to have a similar workflow. Our head of clinical success is a former chief medical officer of a home health and hospice organization. So she's hospice doc, palliative medicine, and emergency medicine trained. We talked about our workflows for emergency medicine, and she was like, I start the note as soon as I see the patient so that I won't forget to write my note. Whereas I will look at the chart, but I don't start my note until I'm ready to document. So I'll look at the chart and then I'll go see the patient and then I'll start the note. We start from a perspective of assume nothing, talk to your clinicians, watch what they're doing, and then listen to them when they say something is irritating. This is again where the patient care comes in. You're trying to diagnose and problem solve. And when you talk to a patient, you listen to what they say, but you have this filter. Is that really the worst pain you've ever had in your life? Really, tell me more, like dig a little bit deeper. Because sometimes you find like the obnoxious things about a workflow might not be related to the button that they want you to move. So they might ask for a button in a different place. And you're like, I don't know that you want a button. I think you just want the technology to work differently and show you the thing without you even needing to click it. And so being able to listen to them, see their workflow, and then understand and design something that really fits in their workflow is huge. Like we really try to take that AI first approach and workflow centric approach. And that means listen to users, respond to feedback, watch what they're doing, and don't assume you know anything about them. We often get asked, oh, can you customize it? It's like, absolutely, because we know that cardiologist number 1 and cardiologist number 2 at the same institution want different things. And then if you take it to a different institution, that's also going to be very different.
And so does that mean that you're essentially having to customize different versions of the tool that you have? And how does that impact production or implementation?
It's less customization and more personal preference. The data is always the same. It's just how do you want it presented? Every clinician has a little bit of a different flavor, like the way they want things presented. Like anytime we've presented things to our colleagues in residency, when we had to present attendings, if some attendings like it, give me the bullets. Other people are like, I want you to tell me about this story from their birth, basically. And being able to understand where people have personal preference, that's just a user experience and user onboarding situation that we can tweak for everyone, but we don't have to reconfigure the entire application.
Oh, that's great. Because I was like, we've used some tools. The pitch is how customizable it is. I was curious how that works. But the principle that you mentioned about assume nothing really stands out to me and underlines why it's important to adapt when clinicians say something isn't working. And that same lesson applies to when we're thinking about equity. If we assume workflows and needs are universal, we risk missing disparities. And we know that AI-driven tools can unintentionally reinforce those inequities. So what safeguards can help ensure that these tools reduce disparities instead of widening them?
It's the Swiss cheese model. So for those of you outside of healthcare, it's basically the idea of you have a lot of layers of cheese that line up. And an error happens if you can get an arrow through one side of that stack of cheese to the other. So if all those holes line up, then that's when you have an arrow. My mental framework for the bias mitigation is along these same lines. There's not going to be one thing that either solves it or creates it. It's probably going to be a multifactorial thing. So we have to add in different layers to try to mitigate bias over time. Layer 1 is have a product that's designed in a way that has at least perspective on where the gaps are. And then as you layer in different areas, you can course correct for the things that are going to be essentially systemic in the medical record in the healthcare world. Like we cannot rescrub the entire medical history of 40 years of somebody's medical care. But what we can do is create layers that kind of flag where those discrepancies might be and create tools to mitigate those discrepancies as time goes on. As an example of this, I was just at a site that was talking about part of their social determinants. There's a region of their catchment area that has no access to clean water. This becomes really important when they're doing maternal fetal health and you're sending home a mom that can't breastfeed and also doesn't have access to clean water. How are they going to make the formula? And those are the kind of things where now that we have tools that we can flag, say, hey, this is the zip code. These are the criteria. This patient might not have access to clean water. Doc, do you want to do something about it? Or social work team, do you want to do something about it? That's the kind of thing where we can try to move the needle in shrinking some of those barriers. You don't have the time to cross-reference the zip code to the disparities in that community. But if you have an AI tool that can flag, hey, this patient might have a disparity, you should probably sort this out before you discharge them with a formula plan. And those are the kind of ways where you can just layer on additional things to try to narrow those disparity gaps in whichever areas that they might happen in.
Yeah. I think you touched on this a little bit. I was curious about how your experiences with the UCSF Innovation Ventures or the WHO actually shaped how you think about equity at a global scale.
My time at UCSF was fantastic because we had a bunch of different applications of technology, but we live in Silicon Valley. That is a bubble in and of itself. We have a different patient population and some of the innovations that come out, because I would do some deal screening for them. So new people trying to create new ideas and new pitches. One of the things that I would do is either do some mentoring and coaching for the people developing those tools or do some screening on the backside. I'd be like, hey, do you think this is viable? And I do that for Stanford and UCSF. It strikes me because of the different things we're trying to solve in the United States, in Silicon Valley, in California, are so dramatically different from trying to apply technology in very under-resourced places through my work at the WHO. Like the challenges there is, do you have water? Do you have electricity? If you have a digital tool, do you have a way to transmit the data? And then it's, okay, so you can transmit the data, but you only have an SMS signal to be able to do that. So you can only do it via text message. And your data is limited, and you might not even have access to that electronic ways. Tech interventions in resource-limited areas have to be low tech sometimes. And when you apply technology, you have to be really mindful about how you do that. And the constraints that you work in are just dramatically different. Being able to understand that, plus like health population things, like understanding the importance of sidewalks and reducing pedestrian deaths, you just don't consider until you go outside of your usual place. And you realize interventions that might seem low tech are the things that have an outsized impact. I love those two kind of experiences because it highlights both ends of the spectrum about what design challenges exist in both environments and how do you solve for them.
That's such an important perspective where equity challenges don't look the same across hospitals, countries, health systems. And at the core is the data itself. These tools are only as strong as the information feeding it or what it's summarizing. In many cases, that information is incomplete or inconsistent. How do you address those challenges when developing these clinical decision support tools?
The nice part is that clinicians are currently trying to make information on incomplete data. Any clarification we can provide is a net positive. I'm used to getting incomplete data. I understand that. But being able to show you, hey, here's additional insight that you may have missed. And as an example of this, for those of you that work in different EHRs with a media tab, sometimes patients will come in with a stack of paper records from an outside facility, and then that gets scanned in or handed to somebody, and then somebody has to review all of that. Or it gets scanned in, but you can't find it again. And if you find it, you're now having to scroll through 40 digital pages of free text information. And so being able to provide just a little bit more clarity in those incomplete information, we're still letting the clinicians do the hard decision-making. Like the tool should not take away decision-making. It's just going to give the clinician as much information so they can make an informed decision as possible. Sometimes that informed decision is telling you that your information is bogus. So don't anchor on information that doesn't have any supporting data. That's a signal in and of itself that helps inform your care. Making sense of that data, making it consumable, even if it's inaccurate, humans are capable of sorting that out as long as you make it obvious to them. And right now, the current state is that we oftentimes can't sort that out in the time that we're allocated. Any additional info is a net positive, but you really need to take a holistic data approach to be able to do that, because then you're just looking at a sliver and it's going to create more problems.
Yeah, the ability to verify information in the moment becomes really crucial. I'm curious what you would say to clinicians who may be working with clinical decision support tools across different types of EHR, or they might be responsible for identifying which support tool can bring into the hospital. What should they be looking for to feel confident that this tool has been safely validated before they rely on it for patient care?
There's a bunch of due diligence around, hey, has it been validated? Do you have any sort of track record? That's all like table stakes. Are you going to protect our data? Are you going to make sure that none of this gets shared? Are you going to build a large language model on the way I treat my patients? Like double check all of that stuff. And if that all works out, don't underestimate the voice of your clinicians, because if your clinicians cannot trust it, and frankly, sometimes it's just put it in their hands and see if they like it. It becomes obvious if you can trust a tool. Like, we don't trust what our colleagues are telling us necessarily. We're always going to verify it. The same thing applies to your tech tools. So if you are evaluating this, if you are evaluating it for either yourself or your practice, try it and trust your clinicians and trust their insight. If they give you the, I don't know if I can trust it, just don't ignore that signal, because I think a lot of times people are trying to apply these things and they purchase them on behalf of their clinicians without letting them play with it or ask them if they trust it. And I don't think it always works out well. So trust your clinicians, see if they trust it, and make sure that nothing is mysterious. Things break down when you give them something that looks like magic, but is mysterious and they can't explain how it came up with that. That raises the antenna of most clinicians. They're like, nah, I can't trust that. Ask your clinicians if they can't trust it, sort out why, and make sure everything you're basing clinical decisions on is transparent.
Involving the clinicians as well will help with the anxiety and the fear about the use of these tools and what AI will do related to their job. Ensuring that one is seeking feedback to shape what is being used can be powerful. Building on that, I'd love to look ahead and just ask which innovations, whether genomics, wearables, or natural language processing, will most transform clinical decision support in the next 5 years?
It's going to be a combination of all of the above. For perspective, I used to be that clinician that was like, dear God, don't give me any more data. Did not want to see your wearable. You're just giving me more data and I don't know how to interpret it. What's exciting now is that the precision medicine we've talked about for like different genetics things about applying a single drug to, we now get precision medicine for all of a patient's care. We can get precision medicine to very granular heart failure treatment based on a patient's data makeup. And genomics is a part of that. And their social determinants is a part of that. And their prior history and all of that aspect. We now are at a place where you can truly synthesize this patient's entire medical history with the current medical landscape and the genomics, and be able to come up with a customized treatment plan that not only aligns with best practices for guidelines for the population, but also best practices for this patient on an individual layer. It's just being able to put it in the hands of everyone. The tech is there, and I'm so excited to be able to see that unleashed on the population, because I think we're really going to have a lot better care that is easier to deliver.
I appreciate your personal reflection on the shift that you shared from feeling overwhelmed by too much data, because I think a lot of patients don't know if they should bring this data. We're all wearing Oura Rings and Apple Watches and Fitbits and all of that. And also when they bring it, sometimes clinicians don't respond positively to it. Hearing that you came from that and was able to shift and leverage the tools that we have to apply it across so many areas of care, I think is really exciting. Really raises the stakes, though, for organizations that want to harness these tools responsibly. What advice would you give healthcare organizations planning to invest in AI-driven clinical decision support tools today?
It still comes down to trust your clinicians. Identify the problem you're trying to solve. People are really excited because AI has a lot of opportunity, and they don't necessarily care what problem it's solving because it's cool technology. So listen to your clinicians, understand the problems that they're coming in with, and then pick a solution that's going to solve that. My last point would be technology is moving so quickly right now that there's a bunch of point solutions and there's different approaches. So some people are like picking something that's going to solve that small problem, and other people are saying, I'm just going to build something internally to solve that problem. Fast forward 2 to 5 years, technology has advanced a ton. And now you have a point solution that maybe that problem doesn't exist anymore. And maybe your thing that you built internally, you have to completely rebuild because of the new technology. While you should focus on the problem you're solving, you also have to pick a solution that's going to grow with you as an org and grow with the tech. Some folks are really tech savvy and they can build their own things and keep up with the pace of innovation. And other people are like, I really want to focus on patients and I want to keep my physicians happy. So I'm going to pick an AI partner that can grow with me as an org and can keep pace with the innovation. That's like that more strategic decision where it's, hey, pick a problem to solve and pick a solution that can grow with you and your organization as the technology and the innovation continues to expand. Because everybody trying to solve today's problem isn't going to be looking out for the problem that evolves in 2-5 years.
I think that's practical guidance for health systems deciding where and how to make investments. As we wrap up our conversation, I also want to zoom back out to you as a leader. You've gone from emergency department to the boardroom, and I think that perspective is rare. How do you foster a culture of creativity and rapid iteration while maintaining clinical rigor?
Emergency medicine is talk to your patient. see how they're doing, get that rapid feedback. And that's one of the things I like about the emergency. You can intervene and then you can see the effect. And translating that into digital medicine or digital health tools is making sure that you have a good, tight feedback loop. That was one of the things at Carbon Health that was really great because we designed technology and we also employed the clinicians. So we had this really tight feedback loop of, do you like this? No. Okay, great. Let us try something different. And here, evidently, too, we just make feedback part of that entire life cycle of our development, where it's like we listen to the users, we hear where they're talking about, and we sweat the small stuff. We deploy, I say, hey, this might seem like a small irritation to you, but you got to tell me, I bet I can fix it with a line of code. We are constantly evolving and iterating, but it's only because we have the amazing relationship with our customers and our feedback loops. And they tell us when things are bothering them or not working, and we see if we can fix it. Feedback is something I wouldn't give up for anything. And I would recommend that anybody building digital tools build in that feedback mechanism because it's how your product will get better, but also it's how your users tend to really know you, trust you as a human, let alone like a software technology. And you can solve the problems that really matter, even if they seem minor to you.
Thank you so much, Kalie. We started this conversation by asking why so many digital health tools go unused despite billions invested. And I think your insights really brings this answer into focus. Building technology that clinicians actually want to use isn't just about more data or flashier features. It's really about trust, transparency, fitting into the real world of clinical care. And your journey from the emergency department to leading innovation evidently shows what's possible when those principles guide design. I know our listeners will take away not only the promise of what's ahead in clinical decision support, but also some of these practical lessons for making it work in their own setting. So thank you so much for chatting with me today.
Thanks for tuning in. This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.